This lecture is about mitral stenosis and anesthetic considerations of mitral stenosis. This is a very important topic from the point of view of examinations and also a very important topic from the clinical point of view, because in India we get a lot of cases of mitral stenosis who come from incidental surgery or non-cardiac surgery, and as the hemodynamics of these cases are very different from normal hemodynamics, it will be good to know about mitral stenosis. What are the lecture objectives? The lecture objectives are understanding the disease, understanding its pathophysiology, its effects on the cardiopulmonary circulation, the hemodynamic effects of mitral stenosis, knowing the clinical presentation of mitral stenosis, what should be the goals for anesthesia, and how do we manage anesthesia in such a case, and lastly, an overview of balloon mitral valvotomy. Mitral stenosis can be defined as an obstruction to the left ventricular inflow at the level of the mitral valve as a result of structural abnormality of the mitral valve, which prevents proper opening of the mitral valve during diastole and hinders the filling of the left ventricle. The predominant cause of mitral stenosis in the developing countries is rheumatic carditis. In the developed countries, the cause is predominantly senile degeneration. Isolated mitral stenosis occurs in 40% of cases, and we can elicit a history of rheumatic fever in about 60% of patients who present with pure mitral stenosis. Apart from rheumatic heart disease, the other cause of mitral stenosis are congenital mitral stenosis, calcific mitral stenosis, chest radiation, and autoimmune disease. Women are more likely to develop mitral stenosis after rheumatic heart disease, and the ratio of women to men in isolated mitral stenosis is 2:1. Usually, there's a latent period of 3 to 4 decades after the onset of rheumatic fever and before the development of symptomatology of mitral stenosis. Anginal chest pain is said to be present in 10 to 20% of patients, while about 23% of the patients also have silent coronary artery disease. This is more so in patients in the Western world where mitral stenosis is more of senile origin. There's an increase in the RV wall tension, which possibly produces an imbalance between oxygen demand and supply, which causes angina in patients of mitral stenosis. It's not due to coronary artery disease per se, but due to a disturbance of the oxygen demand and supply. Coming to the pathophysiology of mitral stenosis. Patients with mitral stenosis have a history of rheumatic fever, which results in leaflet thickening and calcification. There is also commissural fusion of the chordae, and all, or it may be a combination of all these conditions together. The shape of the mitral valve apparatus becomes funnel shaped, and the orifice of the mitral opening is decreased in size. When interchordal fusion is there, it also obliterates the secondary orifices of the mitral valve, while the commissural fusion, which is the primary lesion in mitral stenosis, narrows the principal orifice of the mitral valve. When you look at some diagrams on this, you can see this opening from the left atrium to the left ventricle is to the mitral valve, and the mitral valve, because of its distortion, anatomical distortion, gets narrowed, and the opening makes blood pass from LV to LV with difficulty. If you look at mitral valve from the surface, then this is what mitral stenosis looks like from the surface, from the atrial view. When you look at it from superiorly from the atrium, you see the anterior mitral leaflet, the posterior mitral leaflet, and the fused commissures here. And this is a dissected specimen of the mitral of a patient with mitral stenosis. The normal mitral valve area is 4 to 5 centimeters square. It is said that when it narrows down to less than 2.5 centimeters square, that patients develop symptoms. With the reduction in the valve area, blood can flow from the LA to the LV only under pressure, and that's why a pressure gradient develops between the LA and the LV. The diastolic transmitral gradient is the fundamental expression of mitral stenosis, and it results in elevation of the left atrial pressure, which is finally reflected backwards initially into the pulmonary venous circulation. The characteristic hemodynamic feature of mitral stenosis is an increased left atrial pressure. This increase in left atrial pressure is required as a compensatory mechanism for the stenosis in order to maintain the normal cardiac output. With an increase in the left atrial pressure, the LA dimensions increase, that is, it becomes larger in size. There's a decrease in the compliance of the left atrium, and there's a decrease in the functioning of the left atrium. This adaptive mechanism eventually fails because as the stenosis worsens, the left atrial pressure continues to increase tremendously, and the time needed to fill the LV with blood also increases. Because of this, blood tends to pool more and more into the left atrium, and this increases the pressure gradient between the LA and the LV, leading to dilatation of the left atrium. With dilatation of the left atrium and the stretching of the muscle fibers of the atrium, the patient tends to go into atrial arrhythmia and atrial fibrillation. Once atrial fibrillation happens, it results in a loss of the atrial kick, because atrial kick is there during the end phase of diastole when the atrium contracts and the blood flows with pressure into the left ventricle. Now, with the loss of the atrial kick, blood tends to pool more and more into the left atrium. So the left atrial pressure increases even more. This enlargement of the left atrium consequently leads to an increase in the pulmonary venous pressure because of back reflection of this pressure, and an increase in the pulmonary venous pressure explains why the patient develops dyspnea and hemoptysis as such, in such a case. Increased pressure and distension of the pulmonary veins and capillaries can lead to pulmonary edema as pulmonary venous pressure exceeds the plasma oncotic pressure. This increased pressure is reflected back to the pulmonary arteries further. When the pressure increases in the pulmonary arteries, the pulmonary arterioles react by vasoconstriction, intimal hyperplasia, medial hypertrophy, and all this leads to pulmonary arterial hypertension. The pressure is reflected backwards from the pulmonary vessels further to the right ventricle, and this results in dilatation of the right ventricle due to pressure overload. When the right ventricle dilates, it makes the tricuspid valve incompetent because of an increase in the diameter of the valve, and the patient develops a functional tricuspid regurgitation. This functional tricuspid regurgitation results in distension of the right atrium and leads to right heart failure. With decrease in the mitral valve area further, the diastolic inflow to the LV is maintained by increasing the pressure gradient across the mitral valve. And as there is a reduced flow across the mitral valve, the patient has an underloaded left ventricle. Apart from this, there is a leftward shifting of the interventricular septum because of the dilatation of the right ventricle, which further reduces the left ventricular dimensions. There is a decrease in the left ventricular contractility as there is a decrease in the left ventricular and diastolic volume as per Starling's law. When the left ventricle remains underloaded for a long period of time, the patient may develop left ventricular thickness which is inadequate, and in order to maintain the cardiac output, there's an increase in the afterload which further has an effect on the left ventricle. Pulmonary venous hypertension, as I said earlier, leads to pulmonary arterial hypertension, which leads to RV dilatation, which leads to functional tricuspid regurgitation, and all these together lead to biventricular failure. Low cardiac output results, which is also called as a fixed low cardiac output, as the output cannot be enhanced by hemodynamic manipulation. The body tries to maintain the systemic blood pressure by raising the systemic vascular resistance. There is a phenomenon which is called as second stenosis, and this is typically seen in patients who develop severe mitral stenosis. If you look at a normal patient and look at the pressures in a normal patient, the pressures here are 5 or so in the diastole, in the RA, RV, and in the PA, a maximum of 8. And the same pressures, diastolic pressures, are almost there on the left side of the heart. When the patient develops mitral stenosis, initially in the in the right ventricle, there's a rise in the systolic pressure, and this systolic pressure gets reflected as a rise in the pulmonary pressures also. In the pulmonary, the systolic as well as diastolic pressures rise. However, there is no change as far as the left heart is concerned. But as the mitral stenosis worsens, there is a further rise in the right ventricular pressure, and the systolic pressure may become equal to the systemic pressure, and this leads to pulmonary vascular disease, and which is called as the second stenosis. And this second stenosis causes a rise in the pressures on the left side, and as a result, the flow is reduced because of the decrease in the mitral valve further, and it affects the cardiac output. This slide is a synopsis . This slide is a summary of whatever I have discussed up till now. When we talk about mitral stenosis, we should remember that we should understand the hydraulics of the lesion also. So when we look at the hydraulics, we can calculate, basically from this we can understand what is the problem, and we can calculate what is the defect which is there at the valve. So we use a formula which is called as the Gorlins formula, and Gorlins formula states that the pressure differential across the valve, that is the pressure differential between the LA and the LV, can be calculated by the transvalvular flow rate divided by the hydraulic constant into the valve area, and this is summate is squared, so that gives the gradient of the valve. So indirectly we can say that the pressure gradient is inversely proportional to the square of the valve area. The pressure gradient is directly proportional to transvalvular flow rate, and you can say that pressure gradient is directly proportional to the cardiac output and inversely proportional to the diastolic filling time. What are the hemodynamic effects of mitral stenosis? Generally, mitral valve area greater than 1.5 centimeter square does not produce symptoms. I had said earlier that the patient does not get symptomatic at less than or till the patient's valve area is 2.5 centimeter square or less. While here the difference is that the patient is not symptomatic at rest. So at rest the person gets symptomatic when the valve area is around 1.5 centimeter square or less. An increase in the transmitral flow or a decrease in the diastolic filling period will cause a rise in the pressures in the left atrium and will make the patient symptomatic. The symptoms of dyspnea are usually precipitated by anemia, exercise, emotional stress, infection, pregnancy, or atrial fibrillation, which is associated with a rapid ventricular response. So all these factors make the patient suddenly symptomatic. Why is that so? All these lesions cause an increase in the heart rate. If you see the normal heart rate, which is signified in red here, normal heart rate, there's rapid filling, reduced filling, and then there's an atrial systole followed by a decrease. This is the diastole. So, but what happens in case there's an increase in heart rate, the total diastolic time reduces. And if you see, this filling has to take place in a shorter period of time. And that is what causes a problem. Clinically, an increase in the left atrial pressure causes an increase in the left venous pressure, the pulmonary venous pressure, the pulmonary arterial pressure, and it also increases the pulmonary vascular resistance. This may be a repetition of what we are saying. But this reactive pulmonary hypertension is followed by a permanent change in the pulmonary arterial system, and that is the pulmonary arteriolar hypertrophy occurs, which results in chronic pulmonary hypertension. Pulmonary hypertension is the body's mechanism to shield the pulmonary capillaries from developing pulmonary edema regularly. And however, the pulmonary hypertension precipitates right ventricular failure in form of distended veins, hepatomegaly, edema in the body, and ascites. Whenever there's tachycardia, it further increases the gradient across the valve and it decreases the cardiac output. A rise in heart rate precipitates failure, as happens, as I said earlier, in exercise, anemia, fever, and thyrotoxicosis. And symptoms again are worsened by atrial fibrillation. Apart from the rise in heart rate, which worsens in atrial fibrillation, there's also loss of atrial kick, which also precipitates more failure. Whenever there's a precipitous rise in left atrial pressure or the pulmonary capillary wedge pressure, it results in pulmonary edema. The patient who develops this failure will have shortness of breath. There will be an increased lymphatic drainage due to pulmonary arterial hypertension. The alveolar capillary interface thickens, so exchange of air is not easy. And the increase in pulmonary blood volume and increase in the extravascular lung water further aggravates the problem and results in a decrease in the lung compliance and an increase in the weak mismatch. All these problems together cause an increase in the work of breathing, which is clinically seen as dyspnea. If you look at the clinical course of the disease, typically the murmur, if it appears at the age of 10 years, 10 years later, the patient becomes class 2 in symptomatology, and after 10 more years, the patient develops atrial fibrillation. And further, in case after the onset of atrial fibrillation, by 10 years, the patient will be at least class 3 or class 4 NYHA. This is a typical clinical course. It may occur even faster than this. If you look at the volume pressure loops in such cases, if you see, this is a normal volume pressure loop, LV pressure volume loop. It decreases, it shrinks and shrinks in mitral stenosis, and this decrease is significant because this signifies a fall in the stroke volume of the patient and fall in the cardiac output of the patient. This is a magnified version of the same thing. If you look, this is looking different because the fact is this is probably more representative because the LV pressures in this are shown to be higher as compared to the LV pressures in the mitral stenosis. So LV pressures also fall with time, so this shrinks to this size. So what are the presenting complaints? The presenting complaints of patients are orthopnea, paroxysmal nocturnal dyspnea, fatigue, swelling of feet or legs, palpitation, dizziness or fainting. Patient may have history of hemoptysis, and patient may have history of chest discomfort or chest pain. Less commonly, there may be features caused by the enlarged left atrium, and the features are hoarseness of voice due to compression of the left recurrent laryngeal nerve against the pulmonary artery, dysphagia due to esophageal compression, persistent cough due to compression of the bronchi. Patient may also have features of embolism, embolic episodes, and this is generally seen in patients who are having atrial fibrillation, but even may be seen in patients who are in sinus rhythm, who may have early gone into atrial fibrillation and develop the embolic episodes. These features are features of stroke, renal failure, and myocardial infarction. What is the typical drug history in such patients? These patients have two therapeutic goals, so the drug history is based on these therapeutic goals. The first goal is to reduce the recurrence of rheumatic fever. The second goal in therapy is to provide prophylaxis for infective endocarditis. The third is to reduce symptoms of pulmonary congestion, that is orthopnea and PND. The fourth goal is to control ventricular rate if atrial fibrillation is concerned, and lastly to prevent thromboembolic complications. So the patient is generally on long-term, long-acting antibiotics such as benzathine penicillin. Patients may be receiving diuretics and potassium supplements to reduce the failure. In patients who are in normal sinus rhythm, to prolong the diastolic filling time, decrease the LA pressures, and to control the ventricular rate, in case patient has got AF, patients are generally on careful titrated doses of cardioselective beta blockers or calcium channel blockers. In case the patients have high rate, it is not sensible to do cardioversion to reverse atrial fibrillation, as the sinus rhythm achieved will not stay for a long time and the patient will go back into atrial fibrillation. Some patients who are on treatment with digoxin may come to you. There's some old timers who still use digoxin for rate control of patients with mitral stenosis. Digoxin is basically a positive inotropic agent that blocks AV conduction, and that is why it was used in atrial fibrillation. However, it is very important to remember that digoxin has a very narrow therapeutic range, and it is influenced greatly by drug-to-drug interactions, serum electrolyte concentration, and renal function. So that is the reason why digoxin is no longer in use. It has an antiarrhythmic effect if the plasma digoxin levels are less than 1.1 nanograms per ml in patients with low end diastolic volume. It may have, however, arrhythmogenic action in patients with mitral stenosis, in patients with larger cardiac volumes, patients with plasma digoxin concentrations greater than 1.6 nanograms per ml, even in the absence of signs of digitalis intoxication. Anticoagulation. Patients in atrial fibrillation receive long-term anticoagulation, and usually warfarin is used for this. The target INR is kept between 2 and 3, and the anticoagulation is indicated in patients with both new onset atrial fibrillation and also in patients with paroxysmal atrial fibrillation. Oral anticoagulation is also indicated in patients with history of systemic embolism or with history of LA thrombus, but who are now in normal sinus rhythm. Coming to the clinical features of these patients. When you examine these patients, they've got a mitral facies. What is mitral facies? This is a common question which is asked in examinations. Mitral facies is a pinkish purple patch on the cheeks, and it indicates chronic severe mitral stenosis with low cardiac output and vasoconstriction. Now, why does it appear like this? Why is there hyperemia in a patient who has got low cardiac output? It's basically because the supply of this area is connected to the internal carotid artery, while the other areas of the face get supply from the external carotid artery. Because of redistribution of blood in mitral stenosis, the internal carotid artery continues to get normal blood supply, while the external carotid artery is the perfusion of external carotid artery is reduced. So that is why there's a differential pink patch on the face. The patient may have also jugular distension, and patients in sinus rhythm will show a prominent A wave, which reflects an increase in the RA pressure from pulmonary hypertension and RV failure. In case the patient has got a prominent V wave, it indicates that the patient has also got tricuspid regurgitation. The apical impulse may be laterally displaced or may not be palpable, especially when the patient got severe mitral stenosis due to a decrease in the left ventricular filling. Rarely, a diastolic thrill can be felt at the apex in the left parietal recumbent position. Right ventricular lift is palpable in the left parasternal region in patients with pulmonary arterial hypertension. Remember, the RV lift is in the left parasternal region and not in the right parasternal region. The second pulmonary sound, that is P2, may be palpable in the second left intercostal space due to pulmonary hypertension. On auscultation, patient has a loud first heart sound, an opening snap, and a diastolic rumble. The first heart sound, that is S1, is accentuated because of wide closing excursion of the mitral leaflet. The degree of loudness of the S1 depends on the pliability of the mitral valve, and its intensity diminishes as the valve becomes fibrotic, calcified, and thickened. So this is a very important issue, that the S1 sound goes low pitch and gets lower and lower as time passes in mitral stenosis because the valve gets fibrotic and calcified. S2 is normally split and the pulmonary component is accentuated if pulmonary arterial hypertension is present. So the second part of P2, that is P2, is accentuated. Opening snap follows the second heart sound. Patients present with the classical murmur, which is called as the mid-diastolic murmur. The mid-diastolic murmur is low-pitched, rumbling in character, and it is best heard at the apex in the left parietal position. This murmur commences after the opening snap of the mitral valve, and the duration of the murmur correlates with the severity of the stenosis. The murmur is accentuated by exercise, whereas it decreases with rest and Valsalva maneuver because of a decrease in the LA pressures. In patients with normal sinus rhythm, the murmur increases in intensity during late diastole, which is called as a pre-systolic accentuation, due to an increased flow across the mitral valve during atrial contraction, that is atrial systole. Now, when you look and understand the murmur as the cardiac, as it happens during the cardiac cycle, the duration of the S2 two opening snap decreases with severity of MS. Okay, the duration of the murmur increases with severity of MS. The intensity of the murmur is not indicative of severity, but depends on the pressure gradient across the LA. So this is the pressure gradient across between LA and LV, which you see. So the duration of the if you look at the murmur intensity, depends on this gradient. If the gradient increases, the murmur intensity also increases. What are other murmurs which can be present in mitral stenosis? The mitral stenosis patient may have a high pitch decrescendo diastolic murmur secondary to pulmonary regurgitation, which is also called as the Gram-Steel murmur. And this murmur is audible in the upper sternal border, at the upper sternal border. A pansystolic murmur of TR and an S3 originating from RV may be audible in the left intercostal space, fourth intercostal space, in patients who got RV dilatation. How do we investigate such a case? What are the important investigations? The first is the chest radiograph. The chest radiograph shows features of left atrial enlargement, which are double density shadow in the cardiac salute, a straightening of the left cardiac border due to a large LA appendage, and upward displacement of the mainstem bronchus, prominent pulmonary vessels, redistribution of pulmonary vasculature to the upper lobe, which is also called the stag's antler sign. Some people even refer to it as the sergeant's mustache sign. Mitral valve calcification and interstitial edema, that is Curly's A and B lines. So when we talked about double density shadow, look at this. There will be a difference in the intensity of this area, which has got the right atrium and the left atrium together, and the intensity here. So this is only the LA which is enlarged and which is extended up to this area. So this is a double density shadow because of this. If you look at other features now, so this is the left atrium, this is the right atrial shadow, so double density here again, okay, and then you have a prominent left atrial appendage which straightens up this border of the heart, okay. In this particular case, the patient has had a valve replacement, so an artificial valve or prosthetic valve is also seen, and the patient definitely has cardiomegaly because of right ventricular enlargement and because of left atrial enlargement. Curly A and B lines. Now, curly B lines are commonly seen, and they are seen in periphery as straight lines. These are the curly lines, and they basically signify edema in the interlobar fissures. Curly A lines may be seen, and they are centrally seen here. The straight lines seen in the center, while the curly B lines are seen in the periphery. If the patient has a normal sinus rhythm, then in the ECG you may see P mitral. P mitral is basically a positive bifid wave like this. So this is P mitral, typically seen in mitral stenosis in normal sinus rhythm. But in case the patient has got atrial fibrillation, you will not be able to see P mitral because the P wave is not well formed. In echocardiography, you will find specific finding of mitral stenosis because echocardiography is the most specific and sensitive method of diagnosing and quantifying the severity of mitral stenosis. You should, in echocardiography, you should look at the transthoracic and 2D echo. You should do the Doppler study for transvalvular gradient calculation, PA pressure calculation, and the valve area calculation. A color flow Doppler imaging is done to look for TR and mitral regurgitation. And you should also look for anatomical abnormalities of the stenotic valve, that is thickening, mobility, motion of the valve, and calcification in the 2D echo. You should also look for involvement of the subvalvular apparatus and fusion of the commissures in the 2D echo. A transesophageal echocardiography is important in such cases when you suspect a thrombus. The TE provides better quality images and is more accurate in assessing the anatomy of the valve and the presence of a LA appendix thrombus. While a 3D allows excellent assessment of the commissural fusion and commissural opening after a catheter balloon commissurotomy. This is a typical image of in 2D of a patient with mitral stenosis. Look at this. This is called snowing, also called a self-contrasting of the left atrium. There's no contrast which has been given to this patient because of churning of blood in the left atrium. It appears as there is a smoke in the left atrium. This is very typical of mitral stenosis. If you look at the color Doppler in mitral stenosis, you can see in the valve. See, this is the mitral valve, and you can see the mitral valve. This because of turbulence in flow. You can see this image in the left ventricle and the blood flowing into the left ventricle. And on this side, you can see some amount of tricuspid regurgitation. This is right ventricle, and this regurgitated blood is seen here as the mosaic appearance in the right atrium. This image also, you can see the same thing. Here, the mitral regurgitation is seen more prominently in a patient with mitral stenosis. Look at how small the opening has become. It is only opening this one. This is the excursion of the valves is very, very limited. You can calculate the mitral valve area by a method which is called as planimetry. Planimetry is considered as the reference way to measure mitral valve area. And in this, you actually trace the mitral orifice, including the open commissures in a view during mid-diastole, and you measure the area. More commonly, the mitral valve area is calculated by using the formula and what is called as the pressure half-time method. What is pressure half-time? Pressure half-time is defined as the time interval between, in milliseconds, between the maximum mitral gradient and the time point where the gradient is half. So this is the maximum mitral gradient, this is a minimum. And when it becomes half the mitral gradient, that is the time interval you can say PHT, and mitral valve area is calculated by formula. Mitral valve area is equal to 220 divided by PHT in milliseconds. How do we define the severity of mitral stenosis? As per the AHA guidelines, American Heart Association guidelines, mitral valve disease is considered as mild when the valve area is greater than 1.5, the systolic pulmonary artery pressure is less than 30, and the diastolic gradient is less than 5. It is considered moderate when the valve area is 1 to 1.5, and the systolic pulmonary pressures are 30 to 50, and the gradient is 5 to 10. And it's considered severe when the valve area is less than 1 and the pulmonary pressures are greater than 50 systolic and the mean pressure gradient is greater than 10. Non-cardiac surgery in patients with mitral stenosis. Non-cardiac surgery can be performed safely in patients with non-significant mitral stenosis in case the valve area is greater than 1.5 centimeters square. And also in asymptomatic patients with significant mitral stenosis and a systolic pulmonary artery pressure less than 50 millimeters of mercury. In symptomatic patients or in patients with systolic EA pressures greater than 50 millimeters of mercury, correction of mitral stenosis should be attempted before non-cardiac surgery if it is high risk. What are the anesthetic techniques to be followed? The goals of anesthesia are: number 1, avoid tachycardia as it increases the pressure gradient and decreases cardiac output. So for this, we have to continue the rate control medication up to the day of surgery to control the heart rate. If the patient is on digoxin, omit digoxin on the day of surgery if the pulse rate is less than 80 beats per minute. Number 2 goal is ensure adequate pre-medication to allay anxiety and tachycardia. Remember, excessive sedation may cause hypoxemia, so a small dose of benzodiazepines is what is generally prescribed, or you may use 2 to 4 milligrams of morphine or scopolamine as pre-medication. But remember one thing, pre-medication given to mitral stenosis patient should be under observation and the patient should be given oxygen supplementation after pre-medication is given. The third goal is to maintain pre-operative preload and afterload. What I mean by this is, whatever was the preload preoperatively and afterload preoperatively, the same should be maintained intraoperatively. And lastly, of course, avoid myocardial depression. What all preoperative monitoring should be done? You should monitor the CVP in major surgery. I'm talking about CVP. CVP may not be important as far as the values are concerned, but it provides a good index of RV performance, especially in patients of pulmonary hypertension and patients who have got RV dysfunction and TR. So trending of CVP is very important in such a case. Whatever was the initial CVP, try to maintain the same CVP intraoperatively. We can use pulmonary capillary wedge pressure monitoring also for PCD, but remember, pulmonary capillary wedge pressure tends to overestimate the left ventricular end-diastolic pressure as there is a gradient across the mitral valve. Tachycardia further mismatches the left ventricular end-diastolic pressure and the pulmonary capillary wedge pressure. In case the patient has hypovolemia, it causes reflex tachycardia and increases the pressure gradient. High dose narcotic technique is what is generally recommended to avoid tachycardia. What I mean by high dose narcotic technique is not pure narcotic anesthesia as was recommended earlier. That is very high dose, that is 5 microgram per kg of fentanyl. No, not that, but higher than normal doses of narcotics to be used. We should use non-sympathomimetic neuromuscular agents. The best agent to use in the present conditions is either to use rocuronium or to use vecuronium. But ensure that there is no bradycardia at the induction of anesthesia, especially in patients who have got on digitalis, beta blockers, and calcium antagonists. They may be prone to bradycardia, so we should be careful to prevent bradycardia at induction of anesthesia. We should avoid intraoperative vasodilators because sudden use of vasodilators may decrease the pressure so much that there will be a fall in the cardiac output, the filling pressure of the left ventricle. The induction sequence should be gradual and slow, with low dose of the induction agent to be used. The reason why we use a low dose is because the arm brain circulation time is longer than normal in mitral stenosis because the blood tends to churn inside the left atrium before it enters into the left ventricle. So the drug tends to sort of park itself in the left atrium and very gradually comes out from the left atrium to the left ventricle. But in case too high a dose of an induction agent is given, it may cause sudden systemic vasodilatation and a fall in the systemic blood pressures. We should ensure that there is no pressure response to laryngoscopy and intubation. In case the patient has got pulmonary hypertension, the patient may, in case the patient's cardiac output is tending to be low, the patient may benefit from inodilator use, not a pure inotrope, not a pure vasodilator, but an inodilator use, because it will be a graded form of response. Fluids should be restricted because excessive fluids, if used, can cause pulmonary edema. We should be very careful in using vasoconstrictors in case the patient develops hypotension, as vasoconstrictors can precipitate right ventricular failure because of sudden increase in the pulmonary vascular resistance and the systemic vascular resistance. What about central neuroaxial blockade in patients with mitral stenosis? Central neuroaxial blockade is contraindicated in patients with severe mitral stenosis, as a reduction in the SVR is just not acceptable in such a case. In patients with mild to moderate mitral stenosis, a saddle block or a graded epidural may be given. But remember, we should avoid fluid preloading. In case fluid is required, it should be given as a co-loading process, basically to limit the infusion of volume infused and to maintain the blood pressures according to the volume needed. Opioid-based epidural pain relief can be given if the patient's coagulation profile is normal. Post-operatively, it is important to continue the monitoring and care with the same goals as during anesthesia. So the same goals must be maintained in the post-operative period. There should be excellent pain relief given, because if the patient develops tachycardia, he'll go into low cardiac output. Post-operative fluid management again should be based on the CVP trends rather than given at a fixed amount. And arterial pressures also should be monitored to assess the response to the fluids. This is a very important question, so that's the reason why I'm showing you a little bit about balloon mitral valvotomy. Balloon mitral valve is commonly asked exam, and most of the students who have not been exposed to cath labs are unable to answer this question. So how do you do a percutaneous transvenous mitral commissurotomy, also known as balloon mitral valvotomy? So the access here is through the femoral vein. A guide wire is initially taken first into the right atrium, then through a puncture into the intra-atrial septum, the guide wire is directed into the left atrium, and finally the guide wire passes into the left ventricle. Over the guide wire, the balloon is threaded till the balloon is threaded here, till it reaches the mitral valve here. Once it reaches the mitral valve, the balloon is slowly inflated. If you see here, balloon is slowly inflated, and it develops a dumbbell shape because the mitral valve holds on to the balloon. Once the balloon gets inflated with pressure, it breaks the fibrosis in the mitral valve and opens up the valve, and this is how the balloon, and this signifies a completion of the mitral valve balloon commissurotomy. So remember, this is how we do transcutaneous, transvenous mitral commissurotomy. Thank you very much.